Dr. Sanchoy Sarkar is one of our consultant gastroenterologists from the Royal Liverpool University Hospital and clinical director of the bowel cancer screening in Liverpool and Wirral. And he's going to talk to us today about colorectal polypectomy in the elderly patient. Thank you.
Thank you, Mr. Chairman. It's a real pleasure to be here today, and I'd like to thank Professor Sanders for asking me to talk. So I think this subject is one that's not only a technical challenge, but also one that's a moral challenge. And what I wanted to do is take you through a case which brings out some of these issues and then present the evidence to see what can help us in terms of our decision making. So here's the case. So this is a typical case that was referred to us, to our complex polyp team from St Elsewhere, 79-year-old gentleman with an extensive past medical history, including atrial fibrillation, was on dual antithrombotics, including DOACs, which a lot of these patients are these days, had a CTC for iron deficiency anemia where they found an abnormality, went on to have a colonoscopy which showed a 35 millimeter polyp, which was biopsied, which showed low-grade dysplasia. So I'm going to show you a picture of the polyp. These are the best pictures that were sent to us. And what I want you to do is think about a decision that you're going to make. So there are 6 options, from the least invasive to the most invasive. And what I want you to do is think actually, not as an endoscopist, but actually what's going to be the best for the patient. So when we're deciding on our decision making, I think there's 2 really important principles. The first is do no harm, which is part of the oath as such. This is all about risks and complications. And the second is that we need to do some good if we're going to do an intervention. And the whole thing about polypectomy is that we're trying to prevent cancer as the end point. So we need to try and improve survival in patients that are elderly that have limited survival anyway, or we need to improve their quality of life. So taking the first part first, do no harm. Well, actually, there's a lot of harm we can do in elderly patients just by the colonoscopy itself. And at the bottom is a reference from Colin recent colleagues who does a wonderful article, a review regarding colonoscopy in the elderly. But it talks about the harm that can be caused by bowel prep, by sedation. But when you add polypectomy onto it, you add another dimension, and there's increased perforations and bleeding, each of which can lead to hospitalization and even death. What I wanted to do is summarize 2 large studies around colonoscopy in the elderly to see what the data really shows. So this is published in the Annals of Internal Medicine in 2009, largest series of over 53,000 patients, and they did indeed show that actually polypectomy was the game changer in terms of complications. You can see that there was a significant rebleed and even paralytic ileus. There was a 76% increase in GI complications. On top of that, they also found that actually there was comorbidities that were important, particularly CVA, so COPD, atrial fibrillation, and congestive cardiac failure. They were independent outcomes in terms of causing more harm. The second study is a meta-analysis by Day et al., and this looked at 20 studies. And essentially, the summary is that cumulative adverse events were much higher in patients above 80. They also showed that cardiopulmonary complications were much higher in those above 80. On top of that, the main draw-out themes is that patients above 80 had a 70% increase in adverse events and a 60% increased risk in perforation. So what these studies are telling us really is that actually the polypectomy and complications, particularly in patients above 80, does have significant adverse events. So moving on to one of our other options, which was EMR in the elderly. So here are 2 studies, which I could find probably 2 of the largest studies looking at a series of patients. A study on the left basically shows that there was 49 patients that were over 80, and the study on the right, there was 80 patients over 75. They both showed that there's an increase in bleeding rate post-EMR in elderly patients, both early and delayed. One study on the left showed an increase in perforation rate, and the study on the right showed that lesions above 40 millimeters or patients on double antithrombotics had an increased risk. So remember, our patient had a polyp nearly 40 millimeters and had double antithrombotics. What about the ESD, if people wanted to choose ESD as enthusiasts? Well, actually, there has been a lot of evidence around ESD in the elderly regarding early colorectal cancer. The thing is, in Japan, they define early colorectal cancer as high-grade dysplasia, as we do in the West, and they've shown pretty good results with good en-bloc incision rates. But even in these expert hands, what you're seeing is a high complication rate in terms of perforation of 6.1% and a significant bleeding rate. But what they have shown is that they have a 100% disease-free interval. And finally, our sixth and final option was surgery. Not surprisingly, the elderly do poorly with surgery. This is a study with 24,500 patients, and it looked at colorectal resection in patients below 65, between 65 and 75, and above 75. And what you see is that if you look at the post-op morbidity, compared to those under 65, the over 75s almost have a four-fold increase in morbidity, and then in terms of mortality, it's almost five-fold increase in mortality. So if we can avoid surgery, then I think generally that's a good outcome for the elderly patients. How about the other part of the equation, which is do some good? So when we're thinking about doing some good, if you remember, we're talking about quality of life and increasing survival. Now, in terms of quality of life, there's actually no data that polypectomy improves quality of life in elderly patients, which isn't really a surprise. But when it comes to doing some good and increasing lifespan, what we have to talk about is about the patient's age, about comorbidities, and the final histology regarding the patient, as these will all have a potential outcome in terms of their lifespan. I think this is an interesting slide. It shows a number of things. Firstly, in the UK, that the overall life expectancy is 81.2 years, but there's significant differences. So you can see here there's regional variation, and then, of course, there's male gender variation. And what we're seeing is that if you're a man in the north compared to a woman in the south or in London, you almost have a 7 to 8 year difference in life expectancy. So when you're treating local patients, this is local intelligence that I think can be quite useful. And then age is, of course, related to survival, and we know that over the decades, survival has increased in the elderly. We're shifting the bar to the right. But at the age of 70, we're on a slippery slope. You can see that we're on, like, the top of the black run, and after that, things go south pretty quickly. So finally, what about comorbidities? What about comorbidities? Well, this is a validated scale called the Charlson index, or comorbidity index, which has been validated to show it has a significant impact in predicting survival. These are the comorbidity states, and what you see is that actually, if you look at having a Charlson comorbidity index of 3, if you're under 60, you only have an 81% survival living 1 year. However, if you're 80 or above, you can see that survival reduces to just 63%. So to me, this is a useful tool, and it's something we'll talk about in the study that we did later. Finally, we need to think about the histology. And there's a couple of things. Firstly, not all polyps turn into cancer. I mean, it's actually a small proportion of polyps that probably turn into cancer. That's something to bear in mind. And the other thing to bear in mind is that actually the adenoma-carcinoma sequence takes 10 to 15 years. And these are 10 to 15 years that patients don't have. Okay. So if we're actually going to think about an intervention where cancer is the endpoint and we're going to save lives from cancer, then in these patients we have to intervene later. So I thought we would have to intervene at the high-grade dysplasia point to make any difference to their overall survival. This is an interesting study, which I've only seen in abstract form, that looked at polypectomy in the elderly of 180 patients, so patients above 80. And what they showed, whilst the complication rate was low, 23% of patients died within 5 years. But what's important in the study is actually they looked at polyp size and histology. And what we're seeing is that actually if a polyp is less than 10 millimeters in the patients, you can see, which is obviously the most frequent, the risk of high-grade dysplasia is just 1%. The risk of cancer is 0%. If you go higher, if you go between 10 to 19 millimeters, what we see, the risk of high-grade dysplasia is about 14%. and the risk of cancer is 5%. And then if you go above 20 millimeters, then you get a doubling of the high-grade dysplasia rate. So I think this is quite important when we're thinking about elderly patients and polyps and size, as size is actually a really important factor when we're thinking about polypectomy in these patients. So moving on to our study, we looked at 208 patients with a median age of above 80, with a median follow-up of 30 months. And the size of these polyps were around 20 millimeters in terms of median size. And we stratified all the patients using the Charlson Comorbidity Index. In terms of safety, our outcomes were pretty good. The adverse event rate was only 1.6%. In fact, the post-EMR bleed rate was 0.8%, but this was equal to the cardiopulmonary complications. There was no perforations, and there was a set 5.3% 7-day readmission rate. And I'm pleased to report there was no 30-day mortality. With regards to survival, what we're seeing here is that actually this is the normal survival curve, and within 1 year, we had a 92 or 93% of patients that survived, which is good news, I guess. At 5 years, it was 62.7%. The mean survival post-EMR was 6.7%, and we only had one death due to colorectal cancer, and that death was a patient that was diagnosed as having cancer on the initial EMR. So overall, the outcomes are very, very good if you pick the right patient. When we looked at what factors are important, well, 4 factors were important. First, again, was age. Age above 80 had a significant effect in terms of survival. Then the Charlson index, index score of less than 3 versus greater than 3, again, had a significant impact. And histology, patients with high-grade dysplasia had a poorer prognosis. This graph summarizes the survival curves of patients with a index of less than 3 versus 3 or more. And what you're seeing here is that patients with an index of 3 or more, their survival actually at 5 years was just 40%. However, if you compare that with patients with a Charlson index of less than 3, there was 70%. So there's actually a 30% difference in survival depending on your Charlson index. So finally, final slide really, is to give you some sort of conclusions on what we can think, or when we think about elderly patients and polypectomy in terms of strategy. The first thing to note is that complications, no doubt, are more common in the elderly and potentially more devastating. However, this can be reduced by expertise as well as patient selection. Secondly, the benefits of polypectomy is much, much less in elderly. So as endoscopists, we really do need to think about that we're not thinking about ourselves, we're not thinking about ADR rates, but we're actually thinking about the patients because the benefit of the polypectomy is small, yet the risks of polypectomy are high. So in terms of decision-making, I think MDM and multidisciplinary meeting are really useful. And what would we recommend? Well, we recommend that polyps below a centimetre, there's absolutely no benefit to the patient in terms of removing these polyps. In fact, all you're doing is exposing them to the risk. Histology is important, so patients with high-grade dysplasia or polyp cancers may benefit, so intervening at the histology at the right time. How do you predict that? Well, prediction is often, as we've seen in the Ahmed and Landy study, it can be done by size. So, polyps greater than 2 centimeters have 30% high-grade dysplasia rate. Patients above 80, I think, is something that we have to be very careful about because the benefit for those are either none or very slender, and that's outweighed by the fact that the adverse event rate is really high. Comorbidities, massive factor. As patients get older, they get more and more comorbidities, and what we're seeing is that Charlson index of 3 or more predicts survival, and it's something that may be useful when you're assessing patients. And finally, complications are high when the lesions are above 40, when patients are on double antithrombotics. And I've also put right-sided lesions, cecal lesions there as well. So I've got a minute spare, so I was quite impressed with that. So I'd like to thank the organisers again, and I'd like to thank Professor Sanders for this very kind invitation, and of course you, the audience, for your attention. Thank you very much.
Thank you, Sanchoy, for another great, interesting talk.